Ah oui, oui. Alors, merci beaucoup, Jean-Pierre. À demain. Au revoir. Good morning, everybody. Good morning, Sasamoto.
Good morning, Hudson.
¿Cómo está?
How everything's going?
Everything fine. I'm here in Paris, very cold. I have the tower, the Eiffel Tower behind me, but I cannot be there because it's too cold over there. So I prefer to stay here inside this amazing restaurant here, just in front of the tower. So let me just get it here. Good afternoon, everybody. Good afternoon, Saad, Saudi Arabia. Good morning still, Marcelo Murilo Sasamoto, our neighbor in Brazil. We are broadcasting this Retinawesome from outside. Today is the first presential Retinawesome session we have. It's a pleasure to have here Ashraya Nayaka. We participated together in Pen Ophthalmologica. He's from India. And we are waiting for the other friends to join us and start. This Retinawesome session is open to be presential, but of course, not everybody can travel and participate, but we can still go on online. And that's our way, Saad, that the way we started. And Retinawesome is open for all. And we know that since the beginning of Retinawesome, you know, we started in the pandemics. We are still in the pandemics, but we are not in that position anymore. Things are not so bad as they used to be in the past. And now it's an honor and a pleasure to be here with you again. And I would like to call Dr. Saad Wahid to start off his presentation as keynote speaker. And we are being recorded in YouTube as well, and also another recording from Retinawesome from our Zoom channel. We are going to be spreading this into the Retinawesome channel webpage as soon as we finish the session. Thank you, Saad. So tell us something about Saudi Arabia, such a beautiful country that I really want to know. I'm sure Marcelo wants to visit too. Ashraya might know Saudi Arabia. Do you know Saudi Arabia, Ashraya? Have you been there?
Yes, not yet, sir.
Not yet, yeah. So we could join and make a trip together, everybody, to visit our good friend Saad.
The next Retinawesome.
So Saad, the word is with you now.
Thank you. Thank you very much, Hudson. Well, you know, I'm really looking forward once things will get back together. I think hopefully we will do a Retinawesome here in Saudi Arabia and the city of Jeddah, and I'm sure you guys will like it. I don't want to waste the time, so without further ado, I'm going to share my my slides.
Yeah, it's pretty good now. I see your slides.
Sure. Okay. First of all, thank you very much for this kind invitation. And I was just thinking, what should I talk about? I thought diabetes is a common topic. We all see these patients, we operate in them, and sometimes we're surprised with these cases. So I'll just touch on the indication because I'm sure everybody is aware of that. We do it for tractional diabetic detachments, for vitreomacular syndrome, where we are lucky now to have the OCT, both pre-op and intraoperative OCT. Non-clearing vitreous hemorrhage is becoming more precise now. We look at the degree of hemorrhage, how deep it is, the status of the other eye, the presence of cataract and glaucoma, and finally NVG and ghost cell glaucoma. Now, I hope you all agree with me that it's a very challenging procedure. Even if you're a very experienced surgeon, we've seen cases that start as being very simple and end up with a big surprise or a disaster. There is no doubt that the microinvasive surgery, the introduction of 23, because I was, as well as Hudson, we were trained in the 20 gauge era, but the introduction of the small gauge has definitely allowed us to control the intraoperative parameters and to perform more complex maneuvers. The geometry of the cutters, specifically the 2510K, has also made a major difference in my practice to the surgery of diabetic retinopathy. The basic principle is to try to relieve anteroposterior traction as well as tangential traction, and this is where you use segmentation and delamination. And the idea is to try to either remove the whole membrane or dissect it into small pieces, or at least just segment it and relieve all the traction around it. When we talk about delamination, the simple understanding is just to pull the membrane and the whole thing will come. And I still remember my first case as a fellow with Dr. Givadoni, if you remember him, Hudson. It was a diabetic membrane, which I pulled with the cutter. It was 20 gauge vitrectomy, and the whole thing came in one piece, and he was really surprised. I think it was just beginner's luck. Like in real life, you will see more complex cases where you have to do what we call as a fold back delamination for more softer membrane. You protect the retina by being behind, and you pull with vacuum the membrane, or for more harder membranes, you go with this conformal type of delamination where you try to get into the right plan and cut around these membranes. Now, the direction of delamination is practically the preference of the surgeon. You can either come from in out, which I personally prefer. I think the retina is thicker, the membranes are thicker, your chances of creating iatrogenic hole is less, but there are a lot of surgeons who do outside in, and they do a very good job. Now, I'm just going to show you a couple of surgeries with that shows delamination. This was a vitreous hemorrhage with membrane. This eye has never had any eye surgery. I'm trying to induce a PVD, which is almost always absent in these patients. And you want to make sure you hold these membranes, give them their own time. Definitely, you don't want to pull to create more bleeding. And once you get into the right plan, then you'll be able to separate, as you can see, very gently these membranes. And once you do that, you have to watch the blood vessels around you, because you can certainly induce bleeding and iatrogenic holes. I want to go to the second surgery. This is a more complex with vitreous hemorrhage and more than 1 point attachment, like a table on the posterior pole in the fovea. And if you cannot manage to delaminate all the membranes, you try your best to separate these membranes, opening all the traction, whether it's anteroposterior or tangential traction. And again, as I said, you want to be gentle. I personally, since I started using the 10,000K, I'm very comfortable with unimanual surgery, and I use the cutter both as a scissor and as a forceps. When you go to segmentation, it's more for more adherent membranes, and this is when you're worried the retina is thin, very ischemic, and you don't want to create iatrogenic breaks. So you segment the areas as much as you can. And I just want to show here at the end of the surgery, there was a stump on the optic disc that I tried to reduce as much as I can. I don't pull on these because they're usually vascular, and if you pull in them, they'll bleed, and most of the times they will cause and create more trouble and give the patient post-operative bleeding. This is a few pictures of pre and post patients of diabetic vitrectomies with tractional detachment. We also do diabetic vitrectomy for tractional diabetic macular edema. In this case, I'm trying here to induce a PVD, which is usually induced easily in some cases. Once you've induced the PVD, we stain with membrane blue. I have noticed that diabetics, especially those who have received multiple anti-VEGF injection, will have very patchy staining of ILM, as you can see. And then hence there is sometimes a need to restain these patients. When I do, when I do these patients, when I do their ILM, I try to avoid removing the ILM over the fovea, because you don't want to de-roof the very thin fovea and transfer this into a partial thickness macular hole. So I try to do the ILM around and then leave, you can see the ILM on top of the fovea without going all the way into the fovea. This is the patient after 1 week post vitrectomy and ILM peel in a diabetic tractional membrane. Anti-VEGF and vitrectomy, I think they're very useful. I routinely use them in cases that I think are very vascular. I think they work within 24 hours. If you have a patient with iris vessels, they will dissolve it after 1 day. I usually inject the patient on Tuesday and operate on Thursday. You want to make sure this patient is going to go for surgery. He doesn't have any medical problem, because of the theoretical risk. If you inject them without surgery, you might induce more tractional detachment. Although I think this concept has a little bit been overemphasized, because I have certainly seen patients and they haven't had this bad complications. Some surgeons advise at the end of the surgery also to inject them. Doing phaco or not doing phaco, I think if the cataract is not visually significant, I personally wouldn't like to combine vitrectomy with phaco. I think you might affect your picture by the corneal edema, and the visualization might be actually compromised. Now, I think the idea is to reduce the total number of surgeries. Bottom line, I think the concept of doing a combined or just vitrectomy is still no consensus, and I think it depends on different surgeons, and I'd be very much interested in hearing what you guys think. Which gauge? I remember when 25 gauge came, people were saying you want to leave 23 for denser hemorrhages and bigger membranes. I have done very dense membranes and very thick, dense hemorrhages and very thick membranes with 27 gauge. And I think especially with the 25K, which I'll show a video of, I think these patients will do extremely well. I don't think there's anything you can do with 23, you cannot do with 25. It's another picture. The concept of bimanual versus unimanual, I am generally a unimanual surgeon. I think bimanual is also good. You need to remember that you're going to add one more trocar. I think it's important to remember that if you're going to do bimanual, you have to have good dexterity. A pick or the cutter and a forceps. I think the best thing is to use, a forceps and a scissor if you're going to do bimanual surgery. But again, I think the design of the new cutter might have allowed us to not need to do bimanual in every surgery. But this is still, again, subject to different surgeons. If you ask me, I think the future is in 3D surgeries. I have used them. They definitely increase the depth of field. They have a wider field of vision. And, as for us, after being operating for 20 years, I think they're definitely easier on your neck and your back. I think it's the future to come. You can see how the filters are different. They're very useful when you have a vitreous hemorrhage or you want to do an ILM. So definitely, in my opinion, they're the future to come. This is just a quick video on the use of 25-10K vitrectomy. I'm just going to go through it quickly. I think this surgery I've shown before. You see how you maneuver the membrane by the shape of the cutter. You can get very close to the retina. You can go under the retina, use it as forceps and then as a scissor, and you can certainly release most of the traction. This is a combined, tractional rhigmatogenous detachment. The retina is very thin and mobile, but again, these cutters, as you can see, are very useful. You get very close to the retina. You maneuver the cutter from one side to another, and you are able, as you can see here, to actually dissect these membranes and remove most of these membranes. Here, I'm just completing the PVD, and you see here again, I'm trying to release the traction by gently pulling from one side and then the other, very close to the very thin and ischemic retina, and being able to actually dissect this membrane off the hole, and finally being able to actually completely remove it. Special consideration when you're doing diabetic vitrectomy, I don't think you want to be aggressive in inducing a PVD. These fibrovascular tufts can be very dangerous, and when they bleed, in the past I've used diathermy, but I've noticed most of these patients post-operatively after 6 months they develop holes, and I think it's the ischemia from the diathermy. So I, generally speaking, increase the intraocular pressure, and if it doesn't work, I use laser. I'm not sure if peripheral vitrectomy is very useful in diabetic patients, because this is a posterior disease, unlike doing a giant retinal tear or a peripheral PVR, where you want to be able to treat the peripheral vitreous and make sure you shave the vitreous base. Post-op bleeding is a very common problem. You look at the status of the other eye, the degree of hemorrhage, you do a B scan. I used to be very worried when I see these patients, but now I tend to wait for 1 or 2 months, and they, generally speaking, clear very well. Thank you very much.
Great, Saad. Great slides. And I want to welcome André Jucá, just came in. Bonjour, André Jucá.
Bonjour, vous avez l'air parisien.
Oui, maintenant ici, nous sommes, il y a la Tour Eiffel derrière moi. The tower, not CN Tower, CN Tower is in Canada. The Tower Eiffel is here just behind me, but it's very cold over here, so I'm here inside to be protected against this cold weather in Paris, but everything seems to be cool here. And we were watching our keynote speaker, Saad. Saad, I remember when I came to Toronto, and we started vitrectomy there, and still we used in Toronto the lender systems with the small lenses like that. And after a while, I was doing surgeries with them, with Dr. Diveni, Dr. Lem, Dr. Berger, and I was always telling them, you should better now use wide angle, the Vogue system. They had the Vogue system actually, but it was not so used there. So you were talking about diabetic vitrectomy, vitrectomy at the periphery. Now with the wide angle systems, we see so clear at the very retina periphery that things came much easier now. And I think in that way, because they are easier to be performed, so we see more, we have better instruments, we have better cutters, and I don't use very much the scissors, the vertical scissors, because the cutters, they are so good and so sharp nowadays. When they are coming to 7,000 cuts, 10,000 cuts, 1,500 cuts, 50,000 cuts, and so it's a lot, we are much better on that. And about cautery, you said that you could get some breaks secondary to the cautery, but when I use the cautery for diabetic patients, I go straight to the vessels. I go very, at the focal point where they are bleeding in order to avoid these post-operative bleedings. And it's usually okay, but still they can rebleed. In many cases, even though the surgery often is from the posterior pole. If everything is sorted out and cool in the posterior pole, I use gas. But if not, if we have this retinal detachment in the periphery, so I like using silicone oil. So I would like to hear comments from Ashraya about the diabetic vitrectomy that Saad just showed us. And I love, Saad, the 3D, because you put one picture side by side with the other. And so I think the future in imaging is also 3D, and we are getting there. So Ashraya would like
sir,
to comment on Saad's.
sir. Excellent presentation, sir. Really enjoyed all the slides. Just a couple of points regarding the use of anti-VEGF. Just 2 weeks back, as sir mentioned, I had a presentation on the similar topic on combined retinal detachments. So I have never regretted on using anti-VEGF at whatever timing it is. So the thing is, like I tell my fellows that what is the maximum complication we will have with an anti-VEGF? Maximum the traction might increase a bit, but either way we are going inside to handle all the traction only. So what is more important in using anti-VEGF is avoiding intractable bleeding. So intractable bleeding is something which is very difficult to handle because it compromises the overall visualization. So anti-VEGF is a great thing I would love to use in all my cases, but because of the cost factor, in 90% of the cases I don't use it. But whenever I get a chance, whenever the pathology is very difficult, I invariably use anti-VEGF. We use more of Avastin in India. We feel that works really well. Sometimes even up to 7 days, it gives you very good control of bleeding, intraoperative bleeding. But otherwise, anti-VEGF is something which really helps in having better outcomes. So that is something I wanted to add.
No, I can't agree more with what you said. I think, as I said, there is a theoretical point that if you inject these patients and they don't go for surgeries, for example, because of a medical condition, or sometimes you don't have a bed in the hospital, they cannot accommodate them. But I think this also has been overemphasized. I agree with you. I have seen these patients. They don't usually detach like crazy. All what happens is just a little bit more traction.
Sir, one question, sir. Have you used any buckle in any of your diabetic cases?
That's a good question. As I said, most of the time the pathology is in the posterior pole. So no, truly no. I can't remember when was the last time I put a buckle in a diabetic, but certainly I think one of the indication is a combined, rhegmatogenous traction, especially if it's inferior, as Hudson was saying. Then I need to put a buckle or put silicone.
It's very common that we see these diabetic retinal detachments in the periphery. They are very tractional. As the case I'm going to show you, I have this case that I'm going to present shortly with diabetic retinopathy, but also the patient did not have only posterior disease, also peripheral disease, and sometimes the tractions are so strong that we have to relieve them. So that's why oftentimes it doesn't pay off to put a buckle in the patient at that time, and you're better off doing the normal or regular vitrectomy with the work in the retinal periphery as well. So very cool, great, Saad, great presentations, and Marcelo would like to comment on Saad's presentation.
It was a beautiful presentation, but I agree with you when you said the post-op hemorrhage is usually very common in these patients, in diabetic patients. So it's important to talk with the family and tell them that probably the visual acuity is not going to be perfect at the 1 day post-op, that they need to wait at least, like you said, 15 days, 1 month, maybe.
Perfect. Yes, true.
Just a comment. So we have published a paper on use of silicone oil, whether it is able to prevent vitreous hemorrhage post-operatively. So just wanted to, like, we had a large case series, and the thing is, oil doesn't prevent vitreous hemorrhage. So people who are thinking that oil will prevent vitreous hemorrhage, they're absolutely will be found on the wrong side. So the main thing is we have to absolute proper dissection and hemostasis on table will prevent all the post-operative hemorrhage. And even if it happens, it easily resolves.
Yeah, very good thoughts. And I would like to invite now André Jucá. How are you, my friend?
Excellent.
I know that if you present your case in the next World Congress with a different technique, I'm sure you're gonna get the prize now, because your technique, you know, from what I know that you've shown in the past, was the first of that type. So I was amazed with your technique.
Yeah.
And most of the retinal surgeons, they do, you know, scleral IOL fixations and things. I myself, I perform the regular way. I might have made some with Yamani technique, but not very much. I know you are far more experienced than myself, and I would like you to share your technique and the way you manage those intraocular lenses.
Thank you very much, my friend. I would like to be in Paris to enjoy a nice glass of wine in this nice cold weather. Here is so warm, so hot.
Yeah, I know it's a good place for the wine as well. Even though I don't drink much wine, my wife drinks a little bit. She's just in front of me with this marvelous glass of wine here. And of course, we are in France, so we have French fries as well. Of course, they are from here. And my kid here, Daniel, 3 years old, he's enjoying a lot. He's happy and smiling. He knows he's in a different place. Good place to be now.
I see that there is not, people are not using masks anymore.
I don't see people. You are right. Not very many people using masks. As you see here. Not everybody. See in the restaurant.
Yeah.
Dá hello aí, meu bem. Dá hello.
Hi. Oh, a nice spot.
So not everybody wearing masks here. Yes, because when you are inside, actually when you are outside, it's not obligatory to wear masks. But here, when we are seated, like in Brazil, we don't need to wear masks anymore because we are in the restaurant. But usually around the city, just walking, people are not wearing masks because it's not a rule anymore. So people, as you see, some wear masks, some not. I think that's because of the this is international city, So you see mostly people wearing masks, they are from outside, and people from here, they don't wear masks at all. I don't see anybody.
It's nice that things are getting back to normal in Paris. It gives us hope. It's nice seeing you there in Paris, and a nice spot you got there, and it's nice being with the family and beautiful kids.
It's also vacation time. It's good to be around, and of course we have this great event tomorrow with the President Macron is going to open the ceremony over here for the first international meetings in the medicine, in general medicine, and also ophthalmology and surgery. And so it's great to be here. It's a great spot, and actually it's not that cold. It's cool. It's okay, This, but it's not.
You just came from hot weather, and then the difference make it.
Yeah, I know.
Okay, I will begin sharing my screen, and yes, this is. I try to make a very. There is many techniques, complicated, sophisticated techniques, but I'm always trying to do things the more simple the better for me. So I will try to share with you this small these small changes that we did in this technique that was this is the technique we use 6-0 Pro flange for sclerofixation. You know, there is many options to implant IOL in absence of capsular support. We can use anterior chambers IOL, fixation, posterior chambers IOL to the iris that we enjoy. That technique is very easy also. Transscleral suture posterior chamber IOL or intrascleral fixation that it has been gaining popularity through the time. First cases were described in 2007, but within 2017, with the Yamane technique, this intrascleral fixation techniques rapidly gained popularity all over the world. A Brazilian guy in 2019 described a technique that he used, a Prolene technique fixation, and Asia described this technique using it outside of the eye. We are going to show you the resistance first, that we try to pierce the IOL with this 6-0 Prolene to see if the resistance was really good. And indeed, the resistance was really very, very good, as you can see. We just did this flange to try to, you see that we pierce it at the junction of the optic and optic zone, as we do inside of the eye. We are doing this with this hydrophilic lens, but it works as well with hydrophobic IOL, not of course with old rigid PMA lens, but you see that's very, very resistant. It doesn't tear. We then did this for flange technique. This technique was described by a Brazilian guy, Canabrava. Noted that he's not piercing the IOL. It's just we are not piercing the IOL. We are just passing through the eyelets of this aqueous hydrophilic IOL. Then we are using 4 points of fixation. This IOL, it's very used to fixate it with other kind of suture, like Gore-Tex suture. But here we are using the Prolene and this technique with flanged 6-0 Prolene. This is about the same thickness of a lens like Alcon MA. So you see, it's very, very simple and very stable, because you have here 4 points of fixation, and it's just, you don't have to bury the anything. It's very, very simple, really. And then the IOL is very stable, as you can see. The visual acuity was very good, and there was no, was like a 5 days post-op. So then we tried to do something simpler than that. And this is, we are trying to do, let's try to take the IOL that was down on the eye, get it up. This is a hydrophilic IOL, that's why we are not putting it in sulcus. We are using it, you see, we pierce the IOL inside the eye, just move it, and then do the flange. And okay, now you have one side. And then we are going to do the same with the other side of the IOL. And you pierce at the junction of the optic and optic zone. You see this Furry gauge needle that goes inside. And again, through paracentesis. And again, we have this. And then you just have to cut and put through the needle. And then we are doing that. And this time, with only 2 points of fixation, that seems to be enough. You can do it with 4 points of fixation, but 2 points seems, this is just a temporary for safety flange after we are going to adjust it. And just the other side. And we put it at 2.5 millimeters, so it avoids touching the iris and avoiding the UGH syndrome. And we just insert it and pull out. You see, it's very simple. And then this is, okay. This is really very, very quick. And here we are using the same IOL. So if you don't have the power of the previous IOL and you don't have another IOL, it's very cheap and very convenient because you use the same IOL. It doesn't matter if it's hydrophilic, hydrophobic, if it has capsular support, or if it does not have capsular support. So it's really very, very, still simpler technique than the one described by our friend Canabrava, because you can do it inside of the eye. So this technique has some disadvantage, though. It has this UGH syndrome, although we are doing it a little bit back to avoid it. It may have, like any technique, conjunctival erosions, and this can lead to endophthalmitis. We haven't seen any of that. The lens may be tilted because we are fixating in only 2 points, but since they are 180 degrees apart, we are not seeing that at all. And we have still to follow up for long-term stability, that we think that the 6O is so thick that it's not going to degrade like we see with 9O and even more with 10O. That's it. That's a very simple technique. I think it can help us in some situations that we are not prepared with luxation, like the case of this patient that we did also. This was, I think, was our first case, and the patient got this support. This you see, this is a Alcon lens, a WF. That's an hydrophobic lens. This can be done with multifocal intraocular lenses or even toric lenses. You can do that also. So this was our first case. You see that it's not difficult to pierce the intraocular lens inside the eye. You can do that outside of the eye, of course, with a new lens, but it's easy to do inside the eye.
André, could you enlarge your picture? Put your picture larger. I think
oh,
it's,
of course, sure. Okay. So I'm going to just show this this technique that we use to pierce. Still the needle, you see, and then just go through it. Okay. It's easy to pierce it. This is Alcon lens. I think everybody has used it, so it's no big deal to pierce it. This is, I think, the first case that we did with only two points. And this patient got retinal detachment surgery, and I think it weakens the zonula, and with time, the zonulas just didn't hold the capsular bag anymore. We remove all the bag and then fixate the intercollar lens, because the bag, many times it gets on the way of the lens being on the plane that we wish. Okay. This the second depth. Now we change a little bit. We are doing that, passing the two needles before adjusted. Just give more space for it. Like I said, this was the first case. After some surgery, we just get a little bit easier. We are just adjusting the time and everything. The size of the ideal size is about 3 millimeters. So it's about the ideal size. So now we are doing it much easily. This was the first case, was not difficult for the first case, but yeah. And as you can see, we can do with any kind of intercollar lens, except.
And the IOL gets very well centered. I see no tilt.
No tilt. Yeah. We are doing OCT on this patient, and the lens is really very, very plain. So that's it.
Thank you, André. Merci beaucoup. Ils sont très bien de votre cas de chirurgie vitrétinienne. Alors, je vais demander à Marcelo Murillo pour faire le comment. Marcelo Murillo, vous comprenez bien le français. I would like you to comment on the Andre's cases.
Io parlo italiano. Scusa. Well, one of the things that we need to remember to put these fixation lenses is the age of the patient, where when they are too old, sometimes they can't tolerate long surgery, and we need to avoid choroidals. So it's one of the things. I believe this technique is a beautiful technique applied in some patients, not every patient.
Yeah, me too. I think sometimes with good iris, and it's also an option. But the good thing about it is that you don't have to have an special intercollar lens. You don't have to be prepared for that. And sometimes you are in the surgery and the lens drop and you don't have a good support. So this is just another option to put on, you know, on your ideas, on your box of tools.
Yes, thank you, Andre. Beautiful case.
Thank you.
Can I have a question?
Yes, sure.
So when you go 2.5 millimeter, you don't make a tunnel, you just go directly into the eye?
Yeah, you don't make a tunnel because we are making the flange. So it's really the flange that's going to hold the lens.
Right, because my original understanding is the tunnel is the thing that will prevent the tilt when you do the tunnel. Now, let me ask you, what is the size of the needle where you feed the 6-0 Pronine? What size needle do you use? 30 gauge?
30 gauge, yes, 30 gauge.
And how do you know, or how do you make sure you're piercing the lens on both sides in the same place? Is that, do you have to be, it has to be like this, or just at the junction does not matter?
Yeah, some friends, I have a friend in Brazil that independently, he did about the same thing, but he is piercing in the aptic. But of course, in this case, you have to have a thick aptic and cannot be a per-lane aptic. You can do this technique with a lens like Alcon MA that has any optic, or even no optic, you can do that. Where do I pierce? I try to pierce at the junction of the optic and the optic. So it's about the same position on both sides, and then the lens is going to be stable. We try it in a multifocal intraocular lens. That's is more tricky because it's important to be centered, and it was fine. It was kind of centered, the intraocular lens. So it's always because the patient it wished to have this intraocular lens that was displaced, and sometimes this technique can give him the chance of keeping this multifocal, and it's another option for this situation. Of course, that the tunnel, I think, what holds it is the flange. The flange will retreat a little bit, but then you pull it and do the flange, and it will retreat a little bit, and then we'll hold the intraocular lens. The trick is just to pull it a little bit out of the eye, more than necessary, and then it will retreat, but then the flange will stop the intraocular lens of getting out. Of course, that in a few minutes, the sclera will hold anyway. Everything.
Sure. Have you seen any dislocation or cheese wiring of the proline through the sclera?
No, I've seen one case that was not. I just fixate one side, and the other side I just lost it because I didn't make the flange. Now I do the safety flange to avoid that, and then I have to pierce again with the other eye was already fixated. So, but it was not a big deal. I just pierced it again and did it all together, because I didn't did the safety flange. Now I do the safety flange, and then with the safety flange, I will never lose another side. A safety flange is a good trick for safety, because when you're working on the other side, you just forget this side, and when you see when it's not too long, you can just lose it.
Thank you, Andre. Great case. Thank you.
Thank you again, Andre. And do you want to comment, Ashraya, on Andre's case? Do you perform those intraocular lens fixations? Do you use money technique or any other technique, or any techniques similar to this one from Andre?
Sir, that was a great presentation. Completely new technique, which I have not come across in the last few years. So basically, like we do only ab externo. The ab interno techniques is something which we have not taught in our training also. So we have been doing only ab externo techniques because being a since we do a complete vitrectomy, try and do induce a PVD, do a complete vitrectomy, and by and large we used to do all this sutured scleral fixations, but now we after working with Dr. Rama Agarwal, we only do this handshake technique and intrascleral fixation with this Charot's tunnel. This Charot's tunnel has given a great stability for our IOLs, and I've been using for almost all IOLs. In fact, some of the times I've even used for multifocal IOLs also, and it has given us great results with very, very less complications. But this is something which is really new and can be, as sir said, we can be used it when it's absolutely necessary.
Thank you, Ashraya. And I want to invite now Marcelo Murilo Sasamoto to present his case for Retinawesome Paris. Marcelo, welcome again.
Thank you. Thank you, Hudson. Let me check. Okay. Okay. Você pode escuchar-me?
Sí, muy bien.
Tá bom.
Ça va bien. Very good
Oui, oui.
screen and sharing. The image is perfect.
Excellent. So I'm going to start now. This is a case of a female of 20 months old who suffered an accident with a glass cup, presenting horizontal laceration of 22 millimeters approx, a loss of vitreous and iris, hypotony, and structural loss of the eyeball. So I'm going to start showing the case. We did like actually four surgeries. This is the eye. We start to give the eye some form to continue the examination and exploration of the eye glove. So at the first, we are using some Pfcl 80 to reform those scleral lacerations. And then we use nylon 10 to repair the corneal lacerations. As you can see, the iris is totally, some of the iris, it was really lost, vitreous loss, and we need to give some form, and the hypotony of the eye also was concerning us. Then we always check the equatorial part of the eye. Sometimes some laceration would be really hidden. So we need to check always that part. Then we focus and repair all the eyelids and the lesions of the skin. It was a really very, very unfortunately a case. So we did that also at the same moment. So that was the first surgery, just closing the eye and wait. We wait like 15 days to recover and to see some to enter to the vitreous and to the retina actually, and see what was going on in the retina, what was going on with the retina at the moment because of trauma. So when we enter, we found a retinal detachment. Well, first a vitreous hemorrhage, then retinal detachment. You can see a big hole around next to the optic nerve. So what we did was applying the retina, cleaning all the hemorrhage around the macula. And this big hole was caused by this trauma, this glass trauma. So then we are making an air fluid exchange. I need to put a chandelier because my visualization was not that good. So with the chandelier, I get a better visualization and start to put in some laser. Then as you can see, there's a choroidal in the left part of the screen. So I needed to hurry to finish my second procedure. So we put some silicone oil. The patient was aphakic because of the trauma. I put methotrexate at the end and betamethasone. So my third surgery, it passed like 2 months. And the third surgery was with a new retinal detachment. As you know, this 1 year and 8 months girl, it's difficult to control the position, difficult to, the kids always are playing and moving, and it's really complicated to do pediatric retinal surgery. So we got a new retinal detachment in this eye with PVR in the inferior quadrants. So we perform a new retina surgery. As you can see all the traction, inferior traction that we are seen at the moment. I remove the silicone oil. That's the real appearance of the retina. So I start to clean everything. Make sure that cleaning all the subretinal fluid. And I was saying, make sure that this posterior hyaloid is totally cleaned. So sometimes I use, to make sure that I'm doing that, I use triamcinolone to check if all the posterior hyaloid is removed. And then when I perform this retinectomy, inferior retinectomy, as you can see, I did this Tetris technique that I mentioned 2 retinosomes before. That is cutting the retina as a block to avoid traction. I did that in this little girl. Then we made an air fluid exchange. Apply the retina. I'm just checking if everything is correct. So I'm changing again to fluid to see with triamcinolone if there's any trouble with the hyaloid. Is I remove it everything. Then again I change to air and apply the retina, put some laser, and finishing with silicone oil. My problem was because of all the laceration, I didn't want to make another, put some new trocar or new incision for the silicone oil. So I prefer to use the cornea, made an incision in the cornea and fill the globe with silicone. Because I got a choroidal the last surgery, so that was the real issue. Thank you.
Thank you, Sasamoto. Such complicated case, and you managed very well. You know, sometimes we have to wait, especially in those trauma cases. I usually wait for about 15 days for the hemorrhage to kind of go to the process of liquefaction, and so that you have a better view and better media, a clearer media to actually watch and do the surgery. In this case, you managed very well, and after the second approach with the silicone oil, the image was pretty much better. And I find it interesting that you showed us the use of the methotrexate in this case, and of course, in many cases of PVR. And I would like, I'm very interested in knowing the results from your approach and use of methotrexate for avoiding recurrences, avoiding, you know, especially in PVR and especially in those cases of trauma and hemorrhage. Could you tell us about the dosing and how often you do that? You do methotrexate for what percentage of cases?
Well, in this trauma case, there are some papers that mention the use of methotrexate could help to avoid the cellular proliferation. So I use it in trauma cases, the PVR cases, and it's going very good. The only problem is that you need to use within the intravitreal injections many times. At the beginning, once per week, then once per 15 days, then once monthly to complete maybe 6 months. So sometimes the patients can't collaborate as well as you want to.
But excuse me, in this case, you just use one injection.
No, in the next I use again, so I didn't put it in the video, but I usually do that.
Yeah, it's congratulations. It's a tough case.
Thank you.
I guess would change the scenario of making is that in different steps. If you have an intraocular foreign body, in this case, I think we must go anyway to get it out.
Exactly.
Thank you, Sasamoto. And Francine won't be able to join us. She's still in the surgery. She's got a complicated case over there back in Brazil. And so I'm going to show you my case. I will show you a pretty interesting case. Let me share my screen with you. Just a sec. Oh, thank you. It is there. Can you see my screen?
Sure.
Okay, so let me start. Thank you again for participating into our meetings. This is Retinawesome Paris. This is the first presidential meeting after the pandemics. And we are at the iBank Foundation in Goiânia, Brazil. So this is inverse ILM flap and stuffing technique for traumatic macular hole with PVR and retinal detachment. Pretty tough case because as you see here, the patient has this retinal detachment with retina shortening and also this macular hole. And we are starting doing the vitrectomy and peripheral vitrectomy. You see the retina is detached and has PVR shortening and this large break in the very retinal periphery. So with wide angle vitrectomy macular lens, you are able to see everything, even though the patient has a detachment. After removing the vitreous and doing an fluid exchange, you see the retina is detached there, but still, if you put brilliant blue right at the middle of the macula and make a very good staining of the macular area. And now, after this, you see using PFO to do the peel, we have to find the place, the good place to peel it off. Of course, I wouldn't choose around the macular hole because the retina, the ILM there is very thin. So I chose it temporarily. I'm lifting off the internal limiting membrane, and you see that the silicone, the perfluorocarbon liquid is holding the retina back there and avoiding the retina, the detached retina from causing a trouble during the peel. So the perfluorocarbon helps you a lot. And now I'm choosing the other way around to find the other edge of the internal limiting membrane. As you see here, I'm going round and to go very close to the first peel. And now I have the two areas of peel, and now I will put, as you see here, the internal limiting membrane underneath the hole. As you see here by transparency, you can see that the hole on the side, you see there the internal limiting membrane is at the hole underneath and not touching the retinal pigment epithelium. And you see that the ILM is still attached to the other part, to the inferior part of the retina at the ILM site. And as you see here, I'm showing how is it still attached there. And the ILM is already stuffed in the macular hole. So when I put the first inside the area there, the first ILM, it came in inverted. And now I have to work the retinal periphery because of the shortening and some bleeding due to diabetic retinopathy and vessels. So I went very peripheral. As you see here, you see the retina is being treated and cut with the peripheral retinotomy, but with the help of the perfluorocarbon liquid, things become easier and easier. And now it's still with some bleeding, but we use the endocautery, as I had commented in his case. And I do subretinal vitrectomy as well. And as you see here, the perfluorocarbon liquid attaching the retina all over. And now it's easier to go on and do the endo laser because the retina now is attached. As you see here, we already finished the macular part, and now we are on the second part of the surgery, now doing the direct exchange of perfluorocarbon for silicone oil. You see here, you have to remove the perfluorocarbon up to the last droplet. And with the wide angle vitrectomy viewing systems, that comes a lot easier to do. And that's the case. And we could perform the vitrectomy, treat the macular hole. And as you saw, this macular hole was kind of diamond shaped. And you know that the patient has this history of trauma, so also diabetic retinopathy. And of course, that makes things worse because you have two severe diseases going on there. You know, one is derived from trauma and another is diabetic retinopathy. But that went well. And even though we use silicone oil because it flows inside the posterior chamber, I like having the patient put the position facing down so that the silicone oil would float over the macular area to help close the macular hole and also to keep the retina detached. So thank you very much. And I would like your comments on this case. Thank you.
Congratulations, Hudson. Very nice case, tough case, and good IML peeling, and nice nice idea of using PFL. Have you ever seen a subretinal PFL when you're peeling it? Since it's
No, it never.
Never
no,
could.
it never go down the retina because in this case, the macula had not this detachment over the macula, only the macula hole. So I did not see much of attraction or anything like that. And via perfluorocarbon liquid, because if you put on the macular area, it sort of create this large bubble. The large bubble has a large superficial tension there. So it doesn't go inside the hole at all.
Okay.
Because
Okay.
you know the large amount of perfluorocarbon at the macular area, and the hole is very small. There is no traction, so it doesn't go. It helps you actually grab the internal limiting membrane. I love it. And my professor, Marcos Avila, he loves doing the ILM peel with perfluorocarbon as well. But I learned this without using perfluorocarbon liquid, but after a while, I see it, especially in the retinal detachment cases, that helps me a lot. So it's easier, the surgery becomes safer and safer. If you get ILM and it comes off your forceps and it goes down again, you get it the same spot and lift it up again, and everything goes well. So I think I was afraid at the beginning trying to do that, and that could be probably more difficult, but it's actually it makes the surgery easier and faster for you.
Yeah, I guess I have done some cases like that, but in cases where there is a lot of traction on the retina, I feel that putting another pressure sometimes can make the PFL goes down. But it was a very nice case, very elegant. Congratulations for that. Very nice. Very nice, Andy. Why did you choose silicone oil? Could you think that gas would not work?
No, as I mentioned during Saad's case, because the patient has had this retinal detachment with traction at the very periphery, the retina was shortened. I could have used gas, but I would like a long-standing tamponade like silicone oil, because otherwise I would probably miss the chance and having to get to the OR again and to operate him again because of PVR. So because the retina was shortened like that, and then now it's attached, and I just wanted a better tamponade and a long-standing tamponade. That's why I did not use the gas, because I thought that maybe could last not long enough, and then I could have a recurrence. That's why.
Okay. Nice case. Congratulations.
Thank you, Andre. Thank you, Andre. And I compare, Saad, I compare to your cases that you showed, and you see that at the very periphery, we had some bleeding there from vessels, and you mentioned in your keynote presentation that oftentimes when you do too much of our, to use the eraser to cautery, you might get some holes. But in those cases, the holes that I could have got, they were so peripheral at the edge of the retinotomy that I had to do some retinotomy. I had to do some cautery. Otherwise, it would bleed in the postoperative period. And these patients, they don't bleed at all in the postoperative period because I did the cautery beforehand.
No, I agree. I think your case is different. I think it's a tough case because first of all, it's traumatic, and it combines both posterior disease with a very large and a bizarre shaped macular hole together with a peripheral detachment. So that's a different case, and I think you managed it wonderfully, what you've done. And I like the way you have done your ILM and how you left a small stump at the end, which is actually going to secure your ILM, and the fact that you have done silicone exchange, silicone Pfcl exchange, because I have seen in the past, if you do air fluids exchange, that ILM can just fly and disappear. So I think you've done a great job. Great case, great case.
Thank you. I started doing this exchange since long ago, and after I've done many air fluid exchange, as you mentioned, the ILM simply just came out of the hole. I was so angry. In some cases, I had to peel it off again, and I peel it off again. Some cases, I did the stuffing technique. But now I'm trying to create this technique that I have the stump of the ILM there so that it wouldn't come out. And I also invert the ILM so it comes in the inverted fashion. So if my exchange is slow one, very slow, so that it doesn't come out at all. So I like this technique because that's a way that you keep holding the ILM in place until you get the last droplet of perfluorocarbon liquid. And at the end of the case, everything is there, not even shake it or switch positions. So this is a technique I'm using more now for those complex cases when you have to do your silicone oil and you have to do this exchange. I prefer the direct exchange of perfluorocarbon for silicone oil rather than doing, passing through air beforehand. What do you think, Ashraya? I saw many diabetic patients you presented at Pan Ophthalmologica. I love your cases and congratulations for that. And what did you think of the technique?
Sir, wonderful case. Congratulations. I just wanted to add one point on what Dr. Saad was telling. So the shape of the macular hole is more slit-like or rhomboid shape or diamond shape because of the traction which is involved. When we have a regular idiopathic macular hole, it is more centrifugal. So you will have a round shaped macular hole. When you have an anterior-posterior traction, such as trauma or a tractional retinal detachment. In fact, in combined RD, you can see at the edge of the traction, you will have an oval shape or a slit-shaped holes. So similarly, you have a more rhomboid shaped hole in traumatic macular hole. Traumatic macular holes are a bit difficult to treat because they are usually larger macular holes. So those macular holes need the ILM peeling, mostly in inverted flap technique. So excellent technique. And as Saad sir also mentioned, it is very important to leave the ILM, the stump at the edge of the macular hole, because the moment if you try to peel it off or do a conventional ILM peeling across the macular hole, you tend to lose it, and the scaffold for glial proliferation becomes very, very difficult, and they end up as type 2 closure or a persistent macular hole. So excellent technique, and congratulations on your successful outcome.
Thank you very
Love your
much.
technique. Really love it. Congratulations.
Thank you. Muchas gracias, Marcelo. Muchas gracias. Merci beaucoup. Nous sommes ici à France. And now, yeah, it was excellent. I think this short Retinawesome was one of the best, because we discussed everybody's cases and Saad's case as a keynote speaker. I want to thank you very much, Saad. And I also want to thank you, everybody, and Ashraya for participating with us the first time.
Sure. I have my presentation is still. I still have to present.
Oh yeah, sorry, I'm forgetting. Yeah, you discussed it so much that I was forgetting you. We still have Ashraya to go, and after Ashraya, I'm sorry, you present your next case, and after your last case, we are going to discuss also your case and everybody's case. And I would like André to finish the presentation with, because André has studied here in France in the 1520 Quinze-Vingts. And so after all, André, I would like to close the Retinawesome Paris. Okay, Ashraya, you are the first. I'm also thinking you are the first time in Retinawesome. I was forgetting you, but it was just a joke, just for you to relax, okay? So go on, my friend, and do your presentation. We are ready for you.
Okay, sir. Thank you. Thank you for the privilege, sir. I'll share my.
Just a sec. Okay, now you are sharing.
Yes, sir. Are my slides visible, sir? Yeah. So thank you, Hudson sir, for giving me this opportunity, and thank you, Retinawesome Paris, for having me here. And without any further introduction of mine, so I'm Dr. Ashray from India. I'm a vitreoretinal surgeon. I'll be talking on newer aspects in reducing metamorphopsia after successful retinal detachment surgery, which are associated with giant retinal tear. So, so a lot of times we have great surgical outcomes with all our surgeries. So this is one of my patients who had excellent visual outcome of 7.5, but he was complaining of metamorphopsia, which is usually measured with M charts. That is, and it was about 0.5. So even after successful pars plana vitrectomy after retinal detachment, lot of patients complain with metamorphopsia or decreased image size in one eye, that is the operated eye, which is also known as anisoconia. So this is this is something which we need to address with our newer population, which are getting these retinal detachments, because 6/6 or 6/9 is not enough anymore. So this is what I want to talk about. That is, gross retinal reattachment is a crude measure of surgical success, and there is something which got recently published called HERA, that is high integrity retinal reattachment. So it can be achieved by reapposing as close as possible to its original location with no retinal vessel printing on the fundus fluorescein autofluorescence imaging. This can be achieved and realignment of photoreceptors closer to their original position to their own RPE cell will give you an excellent outcome. And this proper alignment may allow for a better photoreceptor function and superior functional outcomes, because we are moving towards more functional outcomes than on retinal anatomical outcomes. So as we recently saw excellent surgeries with SFIOL. So this is one of my patients who had a dislocation of IOL. And when the dislocation of after the surgery, patient had a 6/6, but at the end of surgery, at the end of 2 months, he was still complaining of glare. So, but we want to achieve something like this. This is another case of dislocated IOL where we have achieved a 6/6, but absolutely centered IOL. So patient does not have glare. So something similarly we want to achieve with retinal detachment without any metamorphopsia. So how do we move from low integrity retinal reattachment, that is called LIRA, to something like high integrity retinal reattachment and make the patient feel really wow about his vision. So today's scope of presentation, I would be talking on problem statement, objectives, and my surgical procedure technique, and how we can do it step by step. So low integrity retinal reattachment is commonly seen in patients who undergo PPV for RD, and presence of LIRA is nothing but presence of retinal vessel imprinting on autofluorescence imaging. So metamorphopsia and anisoconia is very common after successful PPV. So this is please pay attention to the small vessel. So this is actually this is the original location of this vessel. So this vessel, which is the lower arcade, after the surgery moved from this position to this position. This essentially means that there is what was the original macula here, that photoreceptor has moved it here. So this patient complains of metamorphopsia. So even though patients are 6/9, these patients always experience anisoconia. So this is the trial which was published from the University of Toronto. So this they demonstrated that metamorphopsia is measured about 0.3 and be seen in more than 50% of the patients who underwent pars plana vitrectomy had objective vertical distortion. So this is my patient, another patient with a buccal, and we all know buccal always have a high integrity retinal attachment and usually have 6/6 and 6. So this is how the outcome looks like, with a good buccal height, where and absolutely where the retina earlier vessels are there only they go back and attach, and we get a high integrity retinal attachment. So this is another patient who had a low integrity, and this is another patient who had a high integrity. So how do we achieve this? This is the main question. And even in patients who have a GRT, and with the advent of all this wide angle viewing, PFCL, small gauge vitrectomy, Sershot 10,000 cutting systems, with all these things, we are able to achieve 88% of success. But can we achieve HERA in cases like this? So this is a patient who had a young patient who had a 6/6 vision post cataract surgery. He had an uneventful surgery, and after that he had a sudden loss of vision. So this is the whole retina is reflected on one side. This is the bare RP. So can we really achieve high integrity retinal attachment? Is it really possible? So the answer is yes. This is a patient who has achieved it post-operatively. And how did we achieve it is what my whole thought process is about. So to achieve this, we have to prevent slippage for perfect realignment of the photoreceptor to its original RP. And also we have to reduce the formation of ERM for having absolutely no distortion. So how do we do this? So the solutions are, so we have been ardent fans of buccal. So buccal encirclage with the advent of new techniques has to be avoided. I will come to that why it is important. And it should be we should do minimal cryotherapy to prevent ERM. And something which I've been using of late is something which is not yet published, that is Chandler assisted direct Pfcl silicon oil exchange. So encircling buccal has this following disadvantages. One is, yeah, if the height becomes slightly more, then there is radial infolding, which can cause redetachment. And because if the buccal height is not according to the edge of the dent retinal tear, then it can cause fish mouthing and again cause redetachment. And while doing surgery intraoperatively or postoperatively before the retina scars, there can be posterior slippage causing retinal folds and redetachment. So encircling buccal should be avoided to achieve high integrity retinal attachment, and I have evidence for that. So this paper from Baracol et al. Recommends that the buccal should be routinely avoided in patients without PVR. So in PVR, that's a different issue, but without PVR, in the case which I showed, should be absolutely avoided, because it can avoid the creation of retinal redundancy and can avoid guttering and retinal slippage during air fluid exchange. So this Pitcher et al. Also told that buccal did not significantly alter the success rate in GRT associated with RDs. So cryopexy, again, this paper by Sella et al. Has shown that it can be as high as 21%. So excessive cryo can cause more than 50% of ERM. If it is kept less than 5 applications, then we can avoid ERM. So the third thing is slippage is the most feared complication in GRTs and can lead to retinal folds and re-RD. So with small gauge vitrectomy with and better visualization, we can avoid all the compromised outcomes. And if not taken care, then there will be a failure to achieve high integrity retinal attachment. So this is what I'm talking about. This is Chandler assisted Pfcl exchange, where we use Chandler to directly visualize and pump the silicon oil. So this is the Chandler which I've used. So talking about the technique, so this is the technique which been using, and I've done around 7-8 cases. So I put a 25 gauge valved cannulas, do a meticulous vitrectomy, and after the vitrectomy, I make sure that I have removed every ounce of vitreous and do a thorough indentation and shave the vitreous at low vacuum and high cut rate. So, making sure that I don't leave any vitreous from the anterior part of the retina. The most important thing is we have to get rid of vitreous from the edge of the joint retinal tear. So that is very important to avoid any redetachment. At the end of this step, I usually do a fluid air exchange and use brilliant blue to get better staining to avoid any ERMs if present. And the second step is I inject Pfcl under the retinal flap, and you can see it being getting unfolded slowly. This step has to be done extremely slowly so that there are no fish eggs formation. So fish eggs formation can hamper the visualization, and if visualization gets hampered, your surgical outcomes can be different. So once you slowly unfold it without any retinal folds, you make sure that the IOP doesn't increase too much. So you keep a watch on the optic disc. And once everything is done, the Pfcl level should be kept below the level of the fluid level. Otherwise, you will have continuous bubbles like this. And once done, we check the periphery to see if there are any additional breaks, which needs to be lasered subsequently. And at the end of this, we start using laser. So from the anterior edge of the posterior edge of the GRT. So we do it, we do around 4 to 6 rows of laser very meticulously without causing heavy burns, because laser itself can cause retinal breaks. So slowly from edge to edge of GRT has to be done, and the laser should be reached to all the nook and corners of the edge, so that cryotherapy can be avoided. If we really have to do cryotherapy, then it should be kept less than 5 spots per surgery, because it can cause ERM. So after that, after this thorough laser, then we can go ahead with something known as Pfcl exchange. For that, we have to add more Pfcl before putting the fourth port for the chandelier, because the moment you put some amount of Pfcl can leak, and there can be slippage. So it is very important to add on more Pfcl before doing this step. And once we secure the Pfcl in the opposite quadrant of the superior quadrant, that is the inferior quadrant, so that you get direct visualization of the retina. So once you do that, you start injecting silicone oil directly. So this is called chandelier assisted Pfcl silicone oil exchange. And before doing that, we have to aspirate all the fluid from the anterior part of the Pfcl bubble. So this I'm doing it very carefully under direct visualization. Otherwise, this fluid will seep through the retinal edge and cause a posterior blob of fluid. So this has to be meticulously done. And once done, then you start injecting silicone oil under direct visualization. So I'm using Constellation allows you to inject as well as extrude alternatively. You can't do it simultaneously. So I inject the silicone oil slowly, and also I use extrusion mode of Constellation to remove all the silicone Pfcl. So this is the Pfcl bubble which I'm removing it. So this has to be done extremely carefully, because sometimes because of lack of visualization, you can cause inadvertent trauma to the posterior pole. And I have not done a posterior retinotomy, because that itself, laser to that also can cause ERM and cause distortion later. So the last part of the bubble has to be carefully removed, so that you remove all the small bubbles of Pfcl. So this is how.
So you do a direct exchange as well.
Correct. So
Ashraya, very great,
correct,
because PFC makes a good view from the periphery.
So after that, I use like the small part. So I use a vent called which helps me to avoid any overfill of the silicone oil to prevent post-operative glaucoma. So this is the technique, and this is post-operative 1 month. So we get excellent opposition. So you don't see any retinal shifting. So this gives you excellent vision as well as no metamorphopsia. So this is HERA is achievable, and this can be seen in OCT also. You can see ellipsoid zone as well as ELM intact. So, and on fluorescence, autofluorescence also, everything is absolutely perfectly aligned. So this is another case where I've achieved HERA with excellent visual outcome of 6.6 by and metamorphopsia of 0.1. This is a case where I didn't use this technique and got LIRA. So you can see there is this vessel has slightly slipped down by 0.1 to 0.2 millimeters. So this can be seen very clearly on fundus fluorescein angiography. Here the patient only got 6/18 and 0.5 of metamorphopsia. So to conclude, retinal displacement is absolutely real, and HERA is our new goal in RD surgeries. LIRA can be prevented following these steps. Even though metamorphopsia looks far-fetched in these cases, it can be addressed by following these steps. Functional outcomes are also as important as anatomical outcomes. So it is extremely important to move towards the functional outcome. So today is Diwali in India. So thank you for your kind attention. I'll be happy to
Great
take any
technique, Ashraya. You were awesome. You know, I love the way you did the direct exchange and then you left the sclerotomy without the tubing to avoid, as you said, hyperpressure or glaucoma. So when you do this direct exchange, you always put another sclerotomy, just an open one without the tubing itself. So it sorts of lets the pressure escape off. That's why
Sorry, sir, I didn't hear.
you
Hello?
put the extra sclerotomy on the site during your direct exchange of perfluorocarbon for silicone oil. The reason is to avoid the glaucoma, and that could give you the hyperpressure.
Yes, sir. This
So that's why.
yeah, vent actually actually tells you at till what level silicone oil has to be injected. So you have this vent actually prevents all your overfill cases and prevents all your post-operative glaucoma. So you will exactly feel how much the oil is needed inside the cavity.
Yeah, it's a good thing because you put the sclerotomy at the pars plana site, and when the oil lifts up, and of course that would escape, and you see you are on the level. And that might not happen if you have a 5,000 silicone oil, very thick. But usually you know about where you are, so it avoids also keeping the eye with the hyperpressure. And when the oil approaches up, it goes up like that, and sometimes some air bubble could leave the area, and then you see, no, I'm almost done. So very good way to do. I do some things pretty much like you do. And this technique of the X-ray sclerotomy, I'm gonna do in some of my next cases. Thank you very much. And I also want to thank you for being the first time here in the Retinawesome meeting, and all the others. This presentation will be, it's still live in YouTube, and that will be in our Retinawesome channel. So I'm very pleased that you came and shared this knowledge with us. Thank you very much, Ashraya. Thank you, everybody.
Sir. Thank you.
It was
Thank you.
a real pleasure, and happy Diwali for you.
Thank you, sir. Thank you.
Now we are closing the session. Thank you, Ashraya. Have a great night.
Bye, sir. Thank you, sir. Bye.